Hello, and welcome to the GRACE podcast series. My name is Denise Brock, and I am the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast series, we interview patients, advocates, and healthcare professionals to provide the most updated information for our community and to highlight important issues facing those dealing with a cancer diagnosis. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
Hello and welcome everyone. My name is Dr. Medhavi Gupta. Today we'll be talking about breast cancer with brain metastasis. Having metastasis in the brain can be a matter of huge concern both for the patients as well as the medical team. After lung cancer, breast cancer is the most common cancer associated with brain mets. To discuss this topic, today I'm joined by Dr. Nancy Lin. Dr. Lin is an Associate Chief for the Division of Breast Oncology at Dana-Farber Cancer Institute. She's also a Director for the Program for Patients with Breast Cancer Brain Metastasis. She has an extensive research experience on this topic and has authored a number of publications, including the recent study of tucatinib in patients with HER2-positive breast cancer. In addition, she is also an author of the up-to-date section on brain metastases in breast cancer. Welcome, Dr. Lin. Thank you for joining us.
Thank you so much for having me.
So let's talk about the risk of developing brain mets in patients with breast cancer. To start off, does the risk of developing brain mets vary by stage? For example, patients who already have stage 4 breast cancer with disease in lung, liver, etc., do they have higher chances of developing brain mets than patients with early stage breast cancer?
Yes, that's absolutely true. People who present with stage 1 or 2 breast cancer, fortunately, their risk of developing brain metastases is quite small. And in most clinical trials, it ranges from 1% to 2%, even in the higher risk patients who have HER2 positive breast cancer. For patients who present with higher stage disease, stage 3 disease, inflammatory breast cancer, or patients who have residual disease after neoadjuvant chemotherapy, those patients are at somewhat higher risk of developing brain metastases, but still the absolute risk is relatively low. Where the risks really start to go up considerably is in patients who have established metastatic disease. If we look at all subtypes combined, the risk is about 10 to 15% over a patient's lifetime who has a diagnosis of advanced breast cancer. But there are some groups who are much more prone, and those include patients with HER2 positive disease and triple negative breast cancer, where the risk is as high as 40 to 50%.
We know that not all the breast cancers are the same. For example, patients with hormone receptor positive breast cancer have a very different disease course than HER2 positive breast cancer or triple negative breast cancer. So can you talk about the risk of developing brain mets out of these different subtypes?
Yeah, so in patients with estrogen receptor positive, HER2 negative breast cancer, the risk of developing brain metastasis is quite low and probably about in the 10% range. There are some risk factors that potentially increase that risk. One is that BRCA2 carriers who can be prone to ER positive breast cancers do seem to have a higher risk of developing brain metastases, and patients with ER positive PIK3CA mutated breast cancer, at least in one study from Mass General Hospital, suggested that they have an increased risk. In people who have HER2 positive metastatic breast cancer, there is definitely a higher risk of developing brain metastases, but the risk is spread out over time. It doesn't all happen the first year after diagnosis. It can happen sort of over a scattered period of time, but the risk ultimately reaches about 50%. Oftentimes in people with HER2 positive metastatic breast cancer, the brain is an isolated site of progressive disease, so a patient might have very well controlled systemic cancer with their anti-HER2 therapy and then develop an isolated CNS progression. And this is different from triple negative breast cancer, and these patients have a high risk of developing brain metastases as well, But at least in our series from Dana-Farber, what we found is that when patients with triple-negative breast cancer develop brain metastases, first of all, they tend to happen early, often within the first year of diagnosis of metastatic disease. And when they do happen, it often is in the setting of progression of extracranial disease as well. So it seems to sort of behave differently than HER2-positive disease.
So we spoke about a lot of factors that increase the risk of developing breast cancer, be it stage, receptor status, certain mutations. Are there any other factors that play a role, maybe age, or are there any racial differences as well?
Right. So many studies have shown that people presenting with younger age at breast cancer diagnosis have an increased risk of developing brain metastasis, although some of the studies have not sufficiently controlled for like tumor subtype and other factors that also associate with a risk. So I think it's a little hard to totally tease that apart. Patients who have visceral metastases, particularly lung metastases, that seems to also go along with brain metastases. And finally, there are some studies that suggest that patients of African ancestry may have a higher risk of developing brain metastases, whether that's related to the higher rate of triple-negative breast cancer or whether there's something in addition, I think is not totally clear at this point.
Thank you again for joining us. This podcast was made possible by the generosity of sponsorship from our friends at Lilly and Exelexis. Please like and follow us on Facebook and Twitter. Send us feedback, share your story, donate, and visit us for more information at cancergrace.org. Thank you for listening.